Welcome to The Deep End by On Deck, a podcast where visionary builders, creators, and thinkers discuss world-changing stories and ideas. I'm your host, Marshall Kozlov.
In the world of reviews driving revenues or patient satisfaction, in the case of healthcare, impacting a provider's earnings, meaning a clinician's income. Now we're getting to a really interesting world, particularly with telehealth. So I've experienced this firsthand, and I've talked to several people about this as well. Sometimes the best thing a provider could say to me is just have some good old chicken soup and you'll be fine. But I don't want to hear that from my doctor. I want to hear, your penicillin has been called into CVS. Go pick it up. I am worried about the potential over-ordering, I don't know if I want to use that phrase, of prescription medicine, particularly penicillin, antibiotics, because a clinician knows that if I write a script for this patient, they're going to give me a good review. It's a great provider experience, and those reviews will drive more patients to that provider. I'm real anxious on that.
On Deck is where ambitious people worldwide go to start companies, find their next roles, and invest in their careers. The Deep End invites the founders, operators, and investors from the On Deck community and beyond to turn their experiences into the ideas others need to start their own odysseys. Let's dive in. Join me this week in The Deep End is Mark Switaj, co-founder and CEO of Roundtrip Health. Roundtrip is driving better health by providing a full suite of non-emergent transportation options to patients in different care settings across the country. After exploring the health tech market in India last week, we want to revisit healthcare in the United States. Today's conversation is about the social determinants of health. Social determinants of health are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Roundtrip specifically focuses on transportation. 4 million people miss appointments every year because of a transportation barrier. But Mark is able to speak to how organizations more broadly must lean on data insights in order to improve health outcomes. We also talk about how the pandemic has affected the domestic health tech and telehealth landscapes. Mark's comments echo some of the observations that Nikhil Krishnan highlighted in our episode on overcoming the 6 stages of health tech grief that we released back in December. All right, let's dive in. Mark Switaj, welcome to The Deep End.
Excited to be here.
Would love for you just to introduce Roundtrip to us.
Yeah, absolutely. So, what is Roundtrip, right? So, in the most simplistic sense, we are removing transportation as a barrier to wellness. Okay, so what does that mean, right? So crazy stats, right? I got to throw out the stats. 1 in 5 people in the United States misses or delays their healthcare, with transportation being one of the leading reasons. So that's kind of wild. And in fact, I experienced that firsthand, which was really the one of the origination stories, if you will, of the company. I worked frontline on an ambulance, provided direct clinical care, and I saw people giving up on their healthcare. Maybe not because of the complexities around actual care delivery, but because of the challenges, lack of transparency, and the actual ride process. So just imagine, I'm holding a patient's hand. The patient is saying to me, I'm not going to go to dialysis, chemo, radiation, wound care next Tuesday. This ride and getting there has just been an awful experience. And how profound that is, right? So I reflect on those many experiences of patients saying that to me. And of course, if they don't go to next Tuesday's appointment, there will be no following week for many of the folks that ultimately got that ride. So I remember those experiences, and took that American leap about 5, 6 years ago. Actually, it was 6 years ago this summer, to say there's got to be a better way, right? And we'll get into that, but ultimately looking at how we can improve that coordination experience of the patient's population, ultimately with the view of getting them to that betterment of health and well-being.
Yeah, so a couple follow-ups. I'm really curious about this idea of barriers to wellness. So one of them you listed, obviously, in terms of the company, is transportation. Like, what are some of the other barriers to wellness that folks are running into?
Sure. So now we're getting into the topics of social determinants of health, right? So social determinants of health are considered the leading barriers to why somebody would not be able to seek that betterment of health. So as we talked about, transportation is one of the defined social determinants of health. Another one would be housing, the ability to get access to housing. If you don't have housing, obviously you can't focus on your health, right? So that makes a lot of sense. Food, the ability to access food. If you don't have access to food, you won't be able to get access to, or you won't focus on, let's say, your healthcare. These, of course, all make sense. What's pretty interesting is that this list was actually pretty short in the beginning, maybe 4 or 5, I think. And transportation was on that list. And then as folks really started diving into this, that list continues to expand. And again, it all makes sense to me, right? Like, when I saw that I was, again, going back to when I was on the vehicle, I was taking folks oftentimes to an ER. And, in that transport, I'm taking a member of a vulnerable community to the emergency department. One, I know they don't have any money, so they're not going to pay the bill for the cost of that ride. And two, when I'm talking to the patient, really they're going to the ER because they're cold or they're hungry. Or they have nowhere else to go, or there's a mental health consideration. The ER offers those services. You can get a warm bed, you can get a free meal at an emergency department, but that's not the right place for the population. And certainly, many emergency departments and other care institutions, care locations, points of care, face populations using their care points as the primary point of access, and that's not the intended purpose.
So something I'm curious about, I'd love for you to get more into the population that specifically is having this issue with transportation. So for example, I come from an upper middle class background, yet I wasn't really going to, let's just say, checkups or basic like medical practices, especially after college, until I lived deep in New York City and everything was just right around the corner. So it wasn't as if, literally I needed just like the EMT emergency services, but at the same time, making care accessible, knowing that your one medical clinic is just right around the corner, legitimately made something a little easier for me. But I'm also not the type of person you would think of as suffering from the real impacts of the social determinants of health. So speak really about the population that we're thinking about here.
Yeah, absolutely. And that's kind of like the first thing that I talk about when we start explaining this industry. So most people don't even know this industry exists, meaning the idea or concept of social determinants of health. Many don't even know that non-emergency medical transportation exists in the United States. Like, what does that industry even look like? And I'll give you an example. Like we were just talking now, like even in my background, I'm working on an ambulance. Many people think ambulance equals lights and sirens and 911. Yes, that is true. But there's also another side of that industry where those same vehicles, same trained, credentialed folks are transporting individuals to and from medical appointments non-emergently. So an example of that would be somebody that is, confined to a bed. They're living, let's say, in a skilled nursing facility and they need to go to dialysis. We still need that trained crew to move that patient to that medical appointment. But there's no lights, there's no sirens. So that's just, another example of how that industry is constructed. So when we look at social determinants of health, when we go double click on who's the population that's ultimately being afflicted, it's not folks, let's say, like the two of us. We're talking about largely the vulnerable, meaning lower socioeconomic and the elderly. I would argue that does skew into less urban populations, but that my data isn't saying that, right? So we work with Johns Hopkins, which is in the heart of Baltimore, to one of our largest customers. Um, but when we again go deeper on the population that's ultimately being served, lower socioeconomic, the elderly, folks that even at the zip code level, we can begin to see that somebody that lives in this zip code is at higher risk, or as we call it, higher vulnerability for, let's say, having a transportation barrier and thus being unable to get access to that social determinant of health, let's say, getting access to transportation to get to their medical appointments or other social services in the outpatient space. I've had even kind of questions or thoughts. Does this hit harder, let's say, rural populations? And actually, we did a little bit of analysis on this where we polled our care management teams and we asked them. So these are across the customers that we serve. And we serve customers that are in the most urban of locations like Baltimore, like I mentioned, Cleveland and others, all the way to the most rural of locations, sections of our rural Tennessee, Pennsylvania, even as I call it, Eastern California. And we said to them, talk to us about the population you care managers are taking care of. Are they urban, suburban, rural? Where are they? Interesting split. So we found out that no, this is not an urban challenge, a suburban challenge, or a rural challenge. It's all of them. And if memory serves me right, the hardest hit were in urban locations and rural locations. So I found that really, really interesting. And again, we see that by the customers that we're serving, and again, validated through our own research by the care management teams that we work with.
I'm really glad that you broke this into urban, suburban, and then rural. I would love for you just to tell the story of those three regions through the lens of like medical transport. So for example, talking about challenges with transportation in rural parts of the country, like you obviously have to start with the fact there's been massive hospital closures across rural America. A lot of, hospitals were made during the New Deal era. There's been population change. They're older. There are closures, et cetera, et cetera, et cetera. So that's a starting point of that story. But can you just break out what this picture looks like in these three categories?
Yeah, I think there were two things that I heard in there. So let's talk about the breakdown of urban, suburban, rural, and then what I'll call the shift in healthcare. Mm-hmm. So let's talk about the second one first. So you're absolutely correct. There are what I'll call the traditional provider organizations that we may come to mind or maybe top of mind. So like a hospital, for example, is closing. We see that making headlines. The consolidation in health systems, combining with other health systems, what does that mean in terms of reimagined care? We can go down tangents in terms of telehealth, all of the things. But there's a general, for those that are relatively new or curious about how the healthcare system works, I'm not going to be able to get through all of it in this podcast, but I'll just give you some kind of concepts. So in Philadelphia, for example, some may recall a couple of years ago, big hospital in the middle of the city closed. I think Bernie Sanders came into town. What's going on? There's a shift in healthcare, and this has been a long time in the making, of the reimagining the traditional hospital. So I may in the past have gone to seek my total knee replacement at the community hospital. But in 2022, I have options, right? I can go to what's called an ambulatory surgery center, for example. I can get my knee replaced. I can also get my cataract surgery done there. I might have gotten that done in the hospital in the past. So care has been shifting to different care settings. And some may call that shifting from what's called inpatient or, traditional in the bed in the hospital setting to outpatient settings, right? Where it might be same day surgery. That is a massive shift that's going on in the United States. So hospitals are closing, yes, but they're also being reimagined, or the care delivery is being reimagined. Okay. So let's talk about, what that means in the case of urban settings, like where you are. You mentioned that you can go around the corner and get that care. 30 years ago, that care might have been in a hospital, right? So we're seeing the continued growth of primary care clinics, et cetera, which is great. That's expanding access, which I absolutely am a huge proponent of. And there's no question that the more storefronts, the more visibility, the easier it is to access, particularly in an urban setting. So what does it look like in the rural setting? So in the rural setting, we've got, oh boy, it's really interesting. We've got organizations called critical access hospitals, which essentially are a differently positioned hospital that serves a fairly large geographic area, generally speaking. They don't have a very large population to serve, and they are funded differently from our government in order to stay open. But what does it look like for like primary care appointments, particularly in the most rural locations? Yeah, it means, as you can imagine, long distance rides and lack of availability of transportation. So, for example, when we started working with the Geisinger Health System in central Pennsylvania, a fairly rural location, we started doing rides long distances, like 30, 50 miles for somebody to get access to a care setting. Just imagine what it's like for that individual, that patient, right? You've got to go in for your care, and every time, maybe it's dialysis 3 times a week, maybe it's cancer care 5+ times a week. Having to go these long distances, that's going to be quite a burden. I don't know about you, but I certainly would be coming to a point where I don't know if I can continue to do this.
This is kind of the point that I was making earlier about like one medical around the corner. Even with one medical around the corner, that took a bit of a struggle, quote unquote. So I completely agree with that.
Yeah. And I was curious about the telehealth concept. Telehealth is incredible. And certainly I think got propelled forward during the pandemic, now endemic. Though it didn't meet the full needs, and the reimbursement models are still imperfect for telehealth. We did see a whole swath of people that tapped into telehealth. We also saw a level of like pent up healthcare that folks maybe tried telehealth, didn't see the full impact, particularly for higher acuity needs, meaning like greater sickness. And thus, I was curious to see if over the course of the pandemic, people actually, the US population would get sicker. I was curious, right? Because telehealth may work for things like maybe a rash, but for procedures, low-level procedures or elective items, telehealth doesn't work. So I suggest that populations are going to pull back on accessing their healthcare, right? Certainly during a pandemic. So they're going to get sicker. People misrelaying their healthcare are going to get sicker. I'm curious to know what our population is going to look like over the next 5 years. That happened. People pulled back on their healthcare. So that means they got sicker, which I think is going to mean higher hospitalizations, right? So I'm curious to know what the long-term effects are, where in-person wasn't possible, telehealth didn't meet the full needs, particularly for rural populations. I'm super curious on that.
So yeah, there's a million things I want to dive into there. So let's just go deep on the real limits of telehealth part, because I think something I'm really curious about is there's a obvious difference between preventive care, checkups, like those different bits, and emergency services. So something's happened and you need to get to a hospital or type of medical care facility. So to what degree do you think telehealth has been effective? Not merely when it comes to the rashes, but just come to this idea of like improving preventive care, improving checkups, like those different bits.
Yeah, so I rely heavily on data. So I don't have that at my disposal for this question. So these are 100% my opinions. I think telehealth has, in a really weird sense, I am so glad the pandemic propelled the telehealth conversation. Telehealth's been on the radar for a long time. Reimbursement models have been wonky. The ability to use it to get paid appropriately have been, not pristine. And with the pandemic, it became, I'll call it table stakes, right? I do suggest that it had tremendous impacts in terms of expanding access. Uh, if you wanted to get access to a specialist, I don't care if you're urban, suburban, or rural. Sometimes getting a specialist appointment was very difficult.
Mhm.
Did this create a model, a pathway to improve provider productivity? Could they see more patients per hour? Because it's tee everything up, you get on the screen, I have all of your information, let's talk. And maybe a 30-minute appointment is now a 10-minute appointment. So productivity of providers could have gone up. The ability to access specialists when previously that wasn't possible because of the nature of in-person has been reimagined. That I think has just been wonderful, absolutely wonderful. I think, again, there was just this gap between, low-level needs and higher-level needs, which got delayed. And I think that is just, I don't think that's not the fault of telehealth. And if the takeaway from this conversation is like telehealth didn't work, then I'm being misunderstood. Telehealth absolutely propelled forward our country in, I'll call it the 21st century of care delivery.
And that's helpful, then. So I guess a way I'll rephrase the question then, what do you think are the limits of telehealth? So it's not saying that it failed, but I think it's easy to be sitting around in April 2020 and say, we think this is going to shift this forward, and then make a bunch of rosy predictions. What limits do you think we ran? And once again, the data here is complicated, but what limits did you see us running into? Yeah.
So I've got some spicy answers on this, right? So my first one, what's a not a terribly spicy spice? Pepper. is again, this whole challenge of not meeting the greater acuity needs of a population, particularly the sickest population. Okay. Now let me get to some cayenne. We'll call that spicier. Is in the world of reviews driving revenues, or patient satisfaction in the case of healthcare, impacting a provider's earnings, meaning a clinician's income. Now we're getting to a really interesting world, particularly with telehealth. So I've experienced this firsthand, and I've talked to several people about this as well. Sometimes the best thing a provider could say to me is just have some good old chicken soup and you'll be fine. But I don't want to hear that from my doctor. I want to hear your penicillin has been called into CVS. Go pick it up. I am worried about the potential over-ordering, I don't know if I want to use that phrase, of prescription medicine, particularly penicillin, antibiotics, because a clinician knows that if I write a script for this patient, they're going to give me a good review. It's a great provider experience, and those reviews will drive more patients to that provider. I'm real anxious on that because I've experienced that firsthand. I've talked to several clinicians on this. I was misdiagnosed. Going back to the rash example, I did a telehealth consult, and long story short, I was diagnosed with scarlet fever, which that was my response to. For those that can't see, eyebrows raised. Haven't
heard that. haven't heard those words in a while.
Yeah. I completely forgot. I went to school with a neurologist, and I gave her a call, and she put me on speaker, and she was around a bunch of her fellow clinicians at the time when I called her. And I'm on speakerphone, and she goes, okay, describe your symptoms again. And I did. And then she said to them, okay, what would you diagnose? And then they all kind of chattered. And then they said, okay, Mark, yeah, tell the crew here what you got diagnosed as. And I did. And she ultimately said to me, stop taking the medicine immediately. Like, that is not the right medicine for you. Because I said to her, like, Steph, I'm getting sick from the medicine. It was really strong medicine. And I just, like, Eh. And she was right. So I think there's a correlation here of, like I said, patient satisfaction, which has financial impacts to providers in modern healthcare delivery, and the role of, let's say, giving somebody a prescription that they may not need.
Another question I'd ask about, you've made reference to like screwed up like reimbursement processes within telehealth a couple of times. Can you just give context for non-medical provider listeners who aren't thinking about the reimbursement side of these things?
Absolutely. And I have a real life example. So we have a customer that pre-pandemic, was using our technology and booking solid number of rides. Pandemic happened. Rides went down, as is the case like everywhere across the United States, as outpatient appointments were delayed or canceled, etc. And so when we moved to endemic stage and our volume returned back to normal levels and has grown since. And so we had a couple of conversations with this customer. And again, this is a healthcare provider. And we asked them, talk to us about like the role of telehealth in your care delivery. And they said, absolutely. So they rolled out a telehealth model as a way to fill the gap in terms of care extension or care delivery during the pandemic, the height of the pandemic. And then they said, but we realized something. And I said, what's that? They said, what we were getting reimbursed for telehealth consults was a fraction of what we would get reimbursed for in person. So when the world reopened, we shifted back in person because we would make more money. So stuff like that changes the care delivery model. And it's hard because this location serves a very vulnerable population, far below the federal poverty level. So for that organization to give up the revenue that's needed to sustain the care for the community, I understand that they have to respond and do the things that they need to do. I do very much believe that care management teams, the frontline staff that's navigating care delivery for these most vulnerable, are doing what is the right thing for the patient. Dollars aside, no nurse, no social worker is going to be told, all patients must come in, period, if they believe that a teleconsult is the right thing for the population. So, but I do suggest that there are inequities in this healthcare system in the United States. If a provider organization is located in a very affluent community, the way that they deliver care is going to look different than a provider organization that is in a much more vulnerable area. And when it comes to reimbursement models that are not incentivizing the right behaviors, we're going to see stuff like this.
A last question in this vein. Earlier, you were speaking about how the healthcare system is getting reimagined. And I'm really interested in your use of the word reimagined because there's the positive, good version of that. And then there's the consultant speak euphemism for that. So I think everyone can have an image of, let's say a McKinsey consultant comes in to a healthcare system, let's say in rural Georgia, and says, look, we're having to close like all these rural hospitals. I think like more than 10 of them, but that's not a devastating destruction of people's healthcare experiences. That's a reimagination of something. So help us really understand like the good and the bad versions of that word and whether you're optimistic in the long term about this idea of like I said earlier, when I was referencing these rural hospitals, I referenced the 1930s. So I'm perfectly open to the idea that we've learned some things about structure and care and design since, FDR was on in his second term.
Yeah. And I do use the phrase reimagined in a very positive light. I love healthcare. It is absolutely my love. And I am so optimistic for the incredibly brilliant clinicians that are entering, non-clinical support professionals, and in our case, the highly talented technical and non-technical that are looking to position us for the future. What I mean by reimagined. So I don't have this stat, but there are headlines that capture our attention. Like, you mentioned provider organizations, hospitals that are closing. But do we have the statistic on what's been the growth rate and the number of points of care in the United States? Yeah, maybe that 1 or 10 those hospitals closed in those counties, but did 50 outpatient surgery centers open and primary care offices open in that neck of the woods or in the greater area? I suggest the number of points of care in the United States has grown. I could be wrong. But the headline is that the hospital's closed. So the outpatient surgery centers are now taking the inpatient knee replacements. Maybe you would have gone in for your elective into that hospital, but now you're going to go to it in the outpatient setting in your community. There's also a level of competition. So our healthcare providers are competing. I joke in southern New Jersey, there's a road that I can drive down where you literally see market encroachment, where the academic medical center has now entered into New Jersey, but the community provider has now opened up another cancer institute down the street. You've got the Children's Hospital, which is now opening up an urgent care center. All on the same block, you've got 3 to 5 different care organizations putting stakes in the ground, competing with each other for patient populations. This is a little bit of a risky comment. I do suggest that a healthy level of competition does ultimately improve the care delivery in the United States. Healthy level. Some markets are hyper competitive, like the one I just described. 5 different care organizations down the same street. Is that a little bit of a different dynamic? There is, on a much broader sense, a greater consolidation of care institutions in the United States. I'll give you just a quick example, and I know we're running late on time. I talked about how I worked on an ambulance several years ago, but certainly one of my loves and what brought me into the healthcare industry. And I had the opportunity to go back to one of the counties where I worked on the ambulance, and the hospital had taken over that ambulance program that I used to work for. I used to work for a private ambulance company. The hospital took it over because the reimbursement was so poor in this market that no private ambulance company could afford to run the program. So the hospital is now running it. And so I had a conversation with that hospital organization, and I said to them, wow, what's the program like today? And they said to me, they are currently serving about 40% of the entire state through the hospital-run transportation program. I could not believe how large and consolidated the program had become. Though through those consolidations, they've been able to centralize a lot of the overhead into one organization, which saves on cost and allows for the pushing of downstream. That I'm pretty excited about. Also, the data that is becoming available, we can start seeing, is there predictability in who's going to need rides? Can we begin to post vehicles in certain geographic areas because they are more likely to have the next request for a transport? The ability to flex resources becomes greater when you have this type of data and access to data, but of course, alignment across an organization.
Yeah. So 2 more big picture things before we really get to our last wrap up section. I'm interested in the fact that you are consistently during this episode talking about data. I'm curious to what degree has just access to the amount of information we have right now served as a catalyst for improvement in change in the industry? Given the scope of the problems, given the complicated economic, socio-political combinations here, culture, et cetera, data, just talk about that, how and what the limits of just more access to data has been in the first place.
Yeah, the access to data is incredible, though this is nothing new. So the availability of data has been around, patient level data, everything from demographic data to healthcare data, medical information. That's been around for some time. We've moved into an era of insights, though. So 10 years ago, providers have had data, right? But now it's moved into, what do we do with this data? It feels like every chief information officer that we talk with at a provider organization is saying, we're finally starting to tap into that mountain of data and use it for a very meaningful purpose. In our case, I feel like I'm going through that with our company, Roundtrip, where I've got demographic data, I've got ride data, and I've got healthcare data. Can I begin to pull that together into something meaningful? And I'll give you an example. This is an idea that we're kicking around. So let's just go back to my Southern New Jersey model, right? Or example. I know somebody that lives in a lower socioeconomic area, call it Camden, New Jersey, Atlantic City, New Jersey. That individual missed their last 3 medical appointments, okay, and has a cancer treatment scheduled for next week. I know with a high degree of certainty that person is at risk for missing next week's appointment based on these 3 different levels of data. I suggest I can create a vulnerability score, like I mentioned earlier, and proactively approach that individual. Hey, patient Mark, we see you have a cancer appointment on Tuesday. Do you need a ride to get there? Press 1 if yes, and a ride just shows up. There's no care team involved. I don't need social workers or nurses worrying about rides. I don't need patients or family members worrying about rides. That's where we're headed with the data. And that's what's got me so excited, is the ability for us to streamline the experience, meet patients where they are, improve the level of engagement. We know that folks that participate in their healthcare are more likely to access healthcare and to get to that betterment of health. That is the future of healthcare in the United States.
And to understand the business model here, then, what are you suggesting in a world where, let's say, the press 1 were possible, like medical systems would they make more money? Would this, like, how does that work for the actual system in the scenario you just outlined?
Yeah, so we're going to continue to see the shift of healthcare to outcomes, right? So healthcare of yesterday was you do more, you make more. Okay. I often joke about my poor dentist. Oh, I got another cavity, huh? It's another $90 in your pocket, isn't it? So poor dentists, I love you. You're great. I don't have any cavities. I swear I've been brushing and flossing. But as we look ahead, that shift in reimbursement model is going to be yes, the patients you see, but also what is the overall impact of that procedure or healthcare to that patient's outcome? There's often the analogy of, if you go to get your car's transmission fixed, and 10 days later your transmission is busted again, you go back to the mechanic. That's still under warranty. In the United States, you go to get your cardiac surgery. A few weeks later, that same problem exists. That organization can bill again for that same cardiac surgery. So it's a little bit of a perverse incentive. What do you do in that example? What's the best thing from a financial perspective, right? How outcomes are different. Healthcare system, as I think we all know, or many of us know, is shifting, and we are well past the beginning of this into you're going to get reimbursed for a care, and that care is going to include the impact to that patient post-surgery too. And that I'm excited for. So what I see, going back to social determinants of health, where we began, is providers know that social determinants are the leading barrier for folks seeking, accessing, and getting to that betterment of health and well-being. The idea, the concept of provider organizations, health plans, particularly Medicare Advantage, now pouring dollars into food access, transportation access, social services, because that will keep folks active in the community, is where the country is headed. There are some crazy stats. I just briefly mentioned Medicare Advantage. I know we're coming short on time. There are some crazy stats out there that the growth in Medicare Advantage, which, to summarize in a few seconds, is the shift of the government running Medicare to now managed care organizations or brands that we know like Blue Cross and Cigna and Aetna and Humana running Medicare or offering Medicare products to the population. The growth rate in that shift of Medicare Advantage is so big. There was one report that I was reading that it is anticipated to rival the rate of all e-commerce in the United States this decade. It is that big. So I'm really excited about how these health plans are competing with each other, how they are using food benefits, transportation benefits, behavioral health benefits to recruit members to their health plan, which ultimately impacts social determinants of health, which creates a better healthcare system. That's what I'm excited about.
I'd like to close then on Roundtrip, which is where we started right before the social determinants of health question, and ask the obvious question, which has to come up in health tech: why now, right? So 2016, you start 2022. We're in this weird, I don't want to say post-COVID, but also kind of post-COVID in terms of like societal organization perspective. Why not 1999? Why not 2008? Like, why is this specifically the time for this style of company and approach?
Absolutely. So I think we've got a couple of factors at play that we've started to talk about. One, there's a macro shift in the healthcare system to a focus of social determinants of health, right? So 10 years ago, 15 years ago, transportation was viewed as a cost driver. Oh, the cost of that ride is $50, says healthcare provider, says health plan. How do we make that $50 $40? How do we shirk on services, payments to these transportation companies? In 2022, I suggest the pendulum is swinging, or maybe has swung, to say, wait a second, a ride of $50, I guess inflation, $80 for wheelchair transport, let's call it. That is a drop in the bucket compared to a hospitalization, compared to an ER stay. Why don't we make rides more available so that that person that is in a wheelchair that needs to get to an outpatient care point of care, like a behavioral health appointment, here's the $80. Go to that behavioral health appointment, stay active in the community. Don't call 911 because you're having an acute episode and believe that the ER is the right place for you, because it's not. So the timing of this is just incredible. And we're able to show the value of these rides to our customers, right? So we can show who, going back to rural, suburban, and urban, which populations, which locations are accessing these rides, what do the rides look like, what are the disease states for these populations. And we can begin to see the value of rides. So rides look very different for somebody going to cancer care 5 times a week, 5+ times a week, than, let's say, somebody that needs access to rides to go to the gym, particularly for a Medicare Advantage population. So we're really starting to see that the value of the insights is what's driving us into the next chapter of healthcare delivery.
So final question then, to really, because we've gone a lot of different places. This is it's both like deep and like broad, but just give folks, what's just like your 10-year vision for how, so once again, like you just said in the previous answer, we've shifted the focus on social determinants of health. So give us like your ideal vision for the world that Roundtrip is building in, given that discussion point.
Yeah, you probably know my answer on this one. It's all about the insights, right? So I think about the vulnerable population, those that we are ultimately serving, not somebody like me. Okay. My kind of North Star 10-year vision, 10+ year vision, is we've completely removed transportation as a barrier. So folks aren't talking about the rides. They're now focused on the care or the post-care or keep going, contributing to society in a way that they would not have been able to previously. It is incredibly laborious, challenging for vulnerable populations to access healthcare transportation in 2022. It takes on average 20 minutes for a member of the vulnerable community to get access to rides to and from their medical appointments. That's awful. So put it succinctly, transportation is an afterthought for the populations. They're focused on the betterments of health and well-being, and we're making that possible.
Very well said. Mark, this has been really great, really informative. I'm really impressed at your ability to wield the data to produce something approximating an insight, though it's still early days, obviously. But thank you so much for joining us on The Deep End.
Likewise. Thanks for bringing this conversation forward.